Hey there, OCD family community. OCD Awareness Week is in full swing, and our broader OCD Awareness Month is bringing hope, fundraising, awareness, and advocacy. I love it. Also, I really love our third cornerstone of awareness, fam, which is research. So today we're chatting with the amazing Dr. Pia Callesen, Ph.D. and OCD and Trauma Specialist, the compassionate Bronwyn Shroyer, LCSW, as we dive into an introduction to metacognitive therapy for OCD. So settle in and maybe pop some corn. That's a little foreshadowing for later, fam, because we've got some learning to do. I'm Nicole Morris, licensed marriage and family therapist and mental health correspondent. And let me be the first to say, welcome to the family. The OCD family, that is. I am here to create a community of support for family members, spouses, partners, parents, adult children, as there may be adult words, and chosen family of OCD sufferers and their community. I've had over 22 years of experience in the mental health field, but please note that this information does not qualify or substitute as a diagnostic evaluation, therapy, or treatment, and it is presented on an as-is basis. Please follow up with a qualified mental health provider in your area regarding concerns for yourself or loved ones. Thank you for joining us today. Now, let's get started. Okay, fam. So I'm going to keep it brief here in our intro because we've got a lot of wonderful discussion ahead. But today we're focusing on the bedrock, the cornerstone, that is research. Now, why is research so important? Well, this is an oversimplified breakdown, but my take on it is it matters because when you or your loved one is suffering from any sort of disorder, be it mental health related or medical even, we want to know that the protocols we're using will be helpful and not harmful. Is it going to make OCD, depression, anxiety better or worse? Is it going to consider neurodivergent processing or will it pathologize it? I mean, there are a lot of different ways that we could dissect this, but it's one of the reasons why you'll hear me preach if you've hung out for even a minute or two regarding why research is so important. So when it comes to OCD, most of the treatment models we discuss fall under the umbrella of CBT, otherwise known as cognitive behavioral therapy. And then we have another toolbox, medication. But when it comes to therapy, we're also going to learn about yet another toolbox in metacognitive therapy, or MCT for short. So what is MCT? That's the question of the day. And we're going to dive into all of that. But first, let me tell you a little bit more about our guest expert on MCT, Dr. Pia Callesen. Pia is a specialist on the highest level in metacognitive therapy, as well as a supervisor at the MCT Institute and chair of the MCTI Danish branch. She has a Ph.D. from Manchester University and trained with the founder of metacognitive therapy, but I'm going to let her tell you more about that, fam, because I love the story. Additionally, we have our OCD and Trauma Specialist, our sister of another Mr., Bronwyn Shroyer, LCSW. Bronwyn has her own practice, leads talks, participates in pods and live streams with IOCDF. She trains, does consultations, and so much more. And so imagine my delight when Bronwyn carved out some time for the fam to help co-pilot this conversation with me, because I knew she had already cracked into metacognitive therapy for anxiety and depression by Adrian Wells, which, spoiler alert, he's the founder you'll hear more about soon with Pia. And because she is also one of the co-founders of OCD Training School, an online training hub that offers live virtual trainings and on-demand courses for clinicians, self-help course for folks with lived experience of OCD, as well as resources for consultation, a resource hub, and blogs to help with more treatment efficacy and options for our community. In fact, you may hear an ad or two these days when checking out the pod because I've proudly joined OCD Training School as an affiliate, meaning if you sign up for any of their course offerings via my special link, you can support the OCD family community at no extra cost to you. So you can always check out OCD Training School's amazing course catalog by jumping over to ocdfamilypodcast.com/courses, and that includes a live training coming up in February with none other than Dr. Pia Callesen. So if you like what you hear here, I really encourage you to check the course out. And for our replay fam, maybe catching this well after February, don't worry, because we're going to talk about some great resources that Pia would recommend, and she is busy at work to continue researching and training more metacognitive therapists. So don't fret or buy into the belief that it's too late. A little metacognitive joke for you there, because it's never too late to learn about MCT. Okay, so one last housekeeping note before we dive in. FAM MCT is a transdiagnostic approach, which means its utility extends across different disorders, not just OCD. So this is truly a different toolbox that we're going to learn about today. And since we're the OCD fam here in OCD Awareness Month, we're fairly focused on, well, OCD. But for any newer fam joining us, or even folks that go way back with our crew, we know OCD can be triggering. That's the thing, right? These obsessions are intrusive. These doubts construct haunting stories. So we're going to be talking about a range of content today, which can include, but is not limited to, different harm themes, sexual themes, assault, and more. And so while we won't go into details, we are going to explore a myriad of examples where MCT might practice something akin to holding on to a thought, like, what if I could blink? What if I could blink? What if I could blink? Fill in the blank. So we're going to reference this in a couple different ways, and I just wanted you to be aware that these examples will come up. But as we'll learn today, that doesn't mean we have to engage with them, because we're really going to be thinking about how we think about our thoughts, not the content itself. Or as we'll soon hear, we'll go back even further and ask, how much time are we spending handling our thoughts? So proceed with discretion, but I hope you'll join us, because with more options and more toolboxes, there's more hope ahead, better outcomes. And I am here for it. Welcome back to the OCD Family Podcast. Today we are in for a treat, family. We have amazing guests today here to talk about metacognitive therapy, otherwise known as MCT. You may hear us reference it as MCT. And I have the woman, the myth, the legend, Dr. Pia Callesen. And a friend of the fam here and prior guest, we have Bronwyn Shroyer, LCSW, back to hang with us. And I just want to say thank you so much, Pia, and thank you so much, Bronwyn, for coming today.
Oh, thanks for having us.
Yeah. Now, Pia, you are in Copenhagen. I'm going to risk saying this wrong, but my husband used to work for a company that had an office in Copenhagen. And so he's done some traveling there. And something he has brought back to our family is, I'm going to probably mispronounce it, smearboth.
Did you break a bone? Because that's a quite fresh smørrebrød.
Well, he has brought the concept, and we have these open-faced sandwiches for anybody that's like, what is that? All the time, except I'm a little tricky because I can't have rye. I have celiac. So we have to substitute. But other than that, he's like, we got to do this. It's become a lifestyle for us here.
Wow, that's amazing. And do you know all the rules? You know, the cheese doesn't go on the herring. And do you know all the smørrebrød rules?
You know, I probably could use an education in the rules. Yes, but the roast beef or the butter, the mayonnaise, all of it. Yes. So we're so pleased to have you. You really have helped pave the way for us to be able to understand what is metacognitive therapy. And so we're going to start with that conversation today, family. But first, just kind of getting to know you, I would love to hear, like, how did you even get into, if you're open to it, Pia, how did you get into studying metacognitive therapy in the first place?
Well, it's actually, it's a long story, but I'll try to keep it short. But I was doing cognitive therapy for at least 12 years. That was what I was doing. And then I wanted to do some research. I wanted to combine the clinical work with research and just do a Ph.D. So I asked my good friend who reads all the journals, what should I study? What is the good thing to study? And he said, well, there's so many options. You know, there's emotion-focused therapy, there's compassion-focused therapy and schema, blah, 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 and mindfulness and so on. But there are these single case studies that are amazing with metacognitive therapy. So you have 4 severely depressed patients and they are miraculously cured with metacognitive therapy. It's too good to be true. So you need to find out if this is cheating with the data or if it's true. And I was really intrigued and I wanted to find out, of course, in my PhD. So I wrote to Adrian Wells, Professor Adrian Wells, because he is the creator of metacognitive therapy, and asked him to do a PhD, a self-funded one, actually. And he was, after a bit of back and forth, he also wanted to do that. So we did a big trial with depression, a huge trial in Denmark with 178 patients having either cognitive therapy or metacognitive therapy. And the results are amazing. It is true that with cognitive therapy, we cure around 50% of people with depression recover. But with metacognitive therapy, it's 74%. And with other diagnoses like OCD or generalized anxiety, we are up with 80 or 90% recovery rates. So
Oh,
it's really good. It's the best recovery rates ever reported from any method.
wow.
Yeah, I couldn't continue doing cognitive therapy after my PhD, so I had to make a choice because you can't really combine these two methods. They're too opposite each other. Like where thoughts are important in cognitive therapy, they don't matter in metacognitive therapy. So it's not really combinable. You can't do it. And I had to make a choice. So of course I chose the most effective one, metacognitive therapy. So for the last 12 years, around half my career, I've only done metacognitive therapy.
Yeah, wow. That is fascinating. And you know what, family? As we start to learn more from Pia about what is metacognitive therapy, I know a lot of listeners, a lot of people here, even in the treatment community, are more familiar with CBT, cognitive behavioral therapy. And so we may even, and I'm going to kind of write myself a little note here, Pia, that if we can even look at some of the differences, because as you
Mhm.
said, they can't really be integrated. And I find a lot of times, whether we're treating OCD, anxiety, other things, a lot of times we want to be able to combine concepts that
Mm.
don't always combine, right? A common example I see of this in the OCD field is if I'm doing ERP, how can I combine I-CBT with that? And so, really understanding the differences are going to be super, super helpful. So, Pia, help us understand. Metacognitive therapy has an impressive resume. I like that it is so effective. What is this? What is MCT?
MCT is based on a lot of years of research, actually, because Adrian Wells was really puzzled about the cognitive model. He didn't think it fit because he thought, I have a lot of negative thoughts and I'm not depressed. Something doesn't fit here. And that started 30 years of research. And he also made a book, Attention and Emotion, from 1996, where he published all these all this research that he's done. And he wanted to find out what is the main difference between the people who get OCD, depression, and anxiety and the people who don't. Is it their age? Is it the gender? Is it how many traumas they have in their backpack of their life experience? What is the main difference between these two groups? And after 30 years of a lot of research, he realized it was actually how we handle our thoughts. So the most important factor or most important difference was the time we spent handling our thoughts. He also calls it the cognitive attentional syndrome, but it's really just working hard on our thoughts and emotions. So if we dwell on thoughts, we ruminate, we try to get the thoughts away, we use a lot of thought suppression strategies or really just a lot of fighting thoughts and emotions. We try to get them away with mindfulness. We try to soothe ourselves and get rid of thoughts and feelings. And if we do that 10 hours a day, we are worse and we get anxiety and depression. Whereas if we only do it half an hour a day, we don't get anxiety and depression. So this time spent handling our thoughts is really important. And the next research he did was to find out why people spend so much time. Why do some of us spend 10 hours a day fighting our thoughts and feelings where others don't spend 10 hours? What is the difference? And he made some studies trying to interview a lot of people. And why do you do this? Why do you worry 10 hours? It makes you stressed and you can't sleep at night. Why do you do it? And he found the metacognitive beliefs that is the cause of this 10-hour of cognitive attentional syndrome. And people said to him, well, I don't have a choice. It's uncontrollable. I can't control if it's half an hour or 10 hour. I have a lot of problems in my life. And if I have a lot of problems, I can't control how much time I spend worrying about these problems. Not under my control. So that was one answer. It's uncontrollable. And then some people with OCD said, well, it's too risky to leave my thoughts alone. I can't leave them alone because if I leave them alone, bad things will happen. These thoughts are dangerous. I can't just leave them alone. I have to handle them. I have to get them away because otherwise I'll kill my baby or I will jump into the river or I will become pedophilic. I would become psychopath. I can't leave these. They are dangerous. And that was, of course, another reason. He called it a danger belief, a fusion belief, as we call it in OCD. And some people also said, well, it's a good idea. I need to worry. It prepares me. I don't make as many mistakes. I need to spend 10 hours worrying because then I'm more prepared. So he divided these beliefs into 3 categories. So the cause of these cognitive attentional syndrome, which is the cause of mental illnesses, is that we can't control it and we think worrying or thoughts are dangerous, or we think it's useful. So positive beliefs. And so in metacognitive therapy, we challenge and restructure the 3 metacognitive beliefs that undermine the cognitive attentional syndrome.
So if I am hearing and understanding you correctly, and if I get it wrong, because this is all very new to me, please help clarify and set the course. But if I'm hearing you correctly, it's in part, it's this thought handling. I actually love the imagery of that. Like you have a handler, and this is the handler of the thoughts. So the brain is handling these different thoughts, right? And you're saying underneath or behind, even preceding, maybe is a better word, these handling of thoughts are some of these core beliefs that there's a certain cost or danger or maybe even benefit, helpfulness, usefulness to how we are interpreting kind of the relationship to the thought, right? So we
Yeah.
need a handler. Why? Why is a handler employed? It's the analogy I'm going to choose to go with here is because it's the stakes are dire. If we're not prepared, fill in the blank, all that. So there is a belief system, a relationship to why we needed this handler in the first place. And the handler is would the handler more or less be OCD or the mental health disorder or
Yeah.
what is
It would be worry in generalized anxiety. It would be rumination in depression. It would be thought, compulsions in OCD. It would be anything we do to try to dwell on thoughts or get rid of them. So it's just a bit different. So when you have the PTSD, for example, they try to fill out holes in their memory. So they try to make this gap filling, it's called. And so they try to kind of fill out the gaps of the memory from the trauma. So that would be a PTSD thought handling strategy. So we see different strategies across the different diagnoses.
which is a really great point. As I mentioned in the intro, fam, this is a transdiagnostic approach. And so part of what's really exciting here is, especially even if you're a family member going, my loved one is battling OCD and this might be helpful for them. But they may be dealing with their own anxiety or their own depression, maybe their own PTSD. And this is an approach that, again, it's going to depend on the mental health disorder, the types of things being handled, but it's a model in how to deal with handlers, not how to get zoomed into the handlers and dealing with the different aspects of the disorder. Would that be?
Yeah, we do mixed groups. So in my clinic, we have groups we don't even do any assessment on, which diagnosis people have. They just come in from the street and they have different diagnoses. They have stress, depression, anxiety, OCD, and they sit in the same group and they see that they have a lot in common. They think they're so different, but they're not, because this person is suppressing his thoughts, doing lots of compulsions. This person is dwelling and ruminating and trying to solve his problems in his head. This person is problem solving. He's planning all the time. So they have this in common, this cognitive attentional syndrome, this over thought handling. That's the common thing across the different people. And so they spend too much time. So minimum 5 hours a day. Some people spend 10 hours. Some people spend 24 hours. You need to spend more than half an hour to have a diagnosis. That's for sure.
Super interesting that I find it fascinating that you can do a group and it doesn't really matter, like the handler that Nicole's talking about, it doesn't matter what they have. And then also that within, we all know as treatment providers and some of the listeners listening in know that they have more than one condition going on. So OCD and depression or OCD and generalized anxiety disorder. So it's fascinating to be able to think in that mindset of being able to just sit down and one process.
It's one solution across all the problems. We have one solution and it's the same across diagnoses.
Well, and what's interesting is we do this a lot in the OCD treatment field when we talk about subtypes of OCD. We go, well, OCD is OCD is OCD. And so it doesn't actually matter, quote unquote, matter, because for a lot of sufferers going, oh, this shit keeps me up at night, right? So what do you mean content doesn't matter? But it's because our approach, no matter which standpoint we're coming from in terms of our evidence-based practice, our approach is like, well, actually, it's very formulaic in how OCD functions. And so this kind of reminds me, even when we zoom out a whole nother level, that we can go, not only is it OCD is OCD is OCD, but some of these different disorders that feel categorically and vastly different also share mental health is mental health is mental health, if I'm hearing it correctly.
Well, they have the same problem. They have these 3 metacognitive beliefs, and then they spend too much time fighting their thoughts. Dwelling on their thoughts. And that's the commonality across disorders. So we, in contrast to, for example, cognitive therapy, it's based on exposure and so on, this is not based on exposure therapy. So we don't expose, with exposure and response prevention. We don't use that in metacognitive therapy. We restructure those beliefs about thoughts. So we get a more relaxed relationship to thoughts. We realize that intrusions are not dangerous. They are uncomfortable, but they are completely harmless and very normal. And so in order to realize that, we have to restructure the danger belief in OCD, for example. And we use different methods. We use Socratic dialogue, which is more like verbal challenging, and then we use behavioral experiments. But this is more on this meta level. So we try to hold on to uncomfortable thoughts. People try to make me get raped, for example. So Pia gets raped, Pia gets raped, and see if I get raped from the thought, and they see that nothing happens. I don't start hating my mom. I don't become psychopathic, and nothing happens. So it's not dangerous to have these thoughts. And so when you do these behavioral experiments and see that nothing happens, then you get a more relaxed relationship and you realize these intrusions are completely harmless. They're just as harmless as normal negative thoughts, normal trigger thoughts.
The difference there, Pia, if you're looking at it from, in ERP, we would do exposures and people are interacting with a triggering material. And that is usually to bring anxiety down and to notice that you can interact with that, and then your anxiety can come down, or learn some safety learning there and challenge it that way. But in metacognitive treatment, can you expand on how that's different? The reasoning underneath it is different.
Yeah, it's different because we don't base this treatment on exposure. So it's not a matter of underexposure. So we can't cure it by doing the uncomfortable thing again and again and again. And what we see sometimes is this exposure actually becomes a new compulsion. So a lot of OCD people come into treatment in our clinic and they say, well, I'm trying to get this anxiety away, Then it jumps into a different topic. Like, now I'm afraid of the ironing. Now I'm afraid of the ironing. So I'm sitting next to the ironing, holding on to the thoughts and try to get the anxiety away. And so they try to use exposure to get rid of the thoughts and feelings. And so it becomes a new ritual, actually. And because the topic changes and they just have to expose themselves to new topics all the time. It's not the ironer, now it's the children, then it's the fridge, then it's blood, then it's, it's different. And they really spend a lot of time trying to get rid of these anxiety feelings with exposure. But metacognitive therapy is not based on exposure. So OCD is not caused by underexposure. So it's actually caused by these dysfunctional metacognitive beliefs about thoughts. So you have these beliefs that thoughts are dangerous and it's useful to handle them. And so as long as you have these metacognitive beliefs about your thoughts, it's impossible for you not to try to get rid of them.
Yeah.
And so when people get the new approach and they realize these are just thoughts, they don't make me different. They don't change my sexuality. They don't make me do things I don't want to. There are 3 domains in OCD. So we have the thought-action fusions. So my thoughts will make me do things I don't want to, kill my baby, strangle my boyfriend, action fusion. And then we have the event fusion. My thoughts will, change my sexuality to something I'm not, homosexuality, whatever that is, what I don't feel like I am. And then it's object fusion. So thoughts can move into objects and can come back and kind of backfire in that sense. So like voodoo dolls and things. So thoughts can be transferred into this glass of water. And if I drink it, then I will be polluted by my negative emotions. And these 3 domains we identify. And then we do the behavioral experiments testing, which, if it's the action fusion, I make my clients hold on to a violent thought. I'm going to strangle Pia. I'm going to strangle Pia. I'm going to strangle Pia, for example. And then they see that nothing happens. And then I ask them, so how much do you now believe that violent thoughts are dangerous and will make you do things you don't want to? And then this belief, this danger belief, slowly comes down. And when it's down to 0, they don't have OCD anymore because then they have a more relaxed relationship. Of course, some still do the compulsions. And then we move on to a usefulness belief. Because even if they don't have a fusion belief, they know these thoughts are completely harmless. Some people still do compulsions. They still try to get rid of them. And that's because it feels nice. So it's more like peeing your pants. We say that in Denmark. It's nice, but it does, it's nice in the short run to pee in your pants. It gets you the warmth. But in the long run, it's cold. It's a Danish expression. And I think it's really useful in therapy because
American needs to take that expression. That's a great one. I love it.
We have in America, this is like, it's useful on the short term, but not long term. So we call it peeing in your pants useful short term, but not in the long. And so we challenge the usefulness belief, looking at, is these compulsions useful, like peeing your pants useful, or is it really useful in the long run?
Yeah. Can I ask? So I know that there's going to be listeners, and I see you, fam, out there that had maybe only had exposure, for lack of a better word, to something like exposure and response prevention. Is going to hear
Yeah.
the example of making the statement to you, Pia, that is disarming, or at least showing kind of the flaw or the con, the error in the idea that my thought, whether it's thought action fusion or whatnot, has the power and ability to mean that I am dangerous. I think that was on the core belief of danger that you gave the example of. And so I have a feeling, I have a hunch, could be wrong, but I have a hunch some folks more familiar with ERP are going to go, well, that is ERP. You're doing response prevention,
Mm.
and you're engaging in the thing, and you're realizing, like, just avoiding the thought or not having the thought, or even if I feel anxious during the thought, it is a piece of this. We confront it. We're doing these behavioral experiments. And so, to that bit of feedback, because I have a feeling that there will be something in that flavor profile of listeners going, but wait a minute, can you help us understand and differentiate then why it's not, as you say, exposure therapy?
Yeah. Well, actually, it's a little bit interesting because when you look at the effects of cognitive therapy, and they're trying to do some research on that, it's actually a bonus effect that the metacognitive beliefs get restructured in the exposure process. It's more like a bonus, like, like a secondary effect, because we don't have this dialogue around the exposure. You don't say, so how much now do you believe that thoughts are completely harmless and so on? You just do it until the anxiety is down to zero. So it's more, killing the bad feeling exposure.
Yeah.
So, and we don't have this goal in metacognitive therapy. I mean, our goal is to get a new relationship with thoughts. And the most interesting part is that when we look at research, they've done some recent OCD research. The interesting thing is that there's like a link between this exposure and restructuring of metacognitive beliefs. So what you see in these cognitive tests and research is that people are actually getting their metacognitive beliefs restructured by accident, you might say.
Yeah.
And this might actually be what is making cognitive therapy useful in the first place. Like, so you have this accidental effect of people getting a new relationship with their thoughts as a bonus when they do the exposure, but not, this is not the direct hit. It's more like a secondary effect.
I think, and sorry, I had a light bulb moment. Didn't mean to trample on you there as you were explaining that. But what I was thinking is, I think this is the power of fear hierarchies when we think about ERP. If we're targeting core beliefs, core fears, and we're working on it, it's not that we did a certain number of exposures and that's what got us there. Because often, and I'm sure Bronwyn too has had this experience where you might set up a fear hierarchy. And partway through, you have a number of different settings and variable ways of testing this. And the person's already like, actually, that thought doesn't matter anymore. Like they've been able to dismiss it completely because they kind of do come to this conclusion. And often, partway through treatment, we'll go, do we have to restructure this hierarchy? Because, yeah, this isn't my big bad something here that I need to kind of figure out. My brain has, like, if we think of obsessions as those sticky thoughts, it's not stuck anymore, right? My brain was able to let that go, but this over here, right? And so then we start, and I think it is a little bit of that process of the surprise recognition that I don't need to relate to the thought that was driving this fear in the same way. But it is kind of going in the back door through the behavioral intervention and going, oh, actually, the initial thought that kind of cascaded this whole fear and part of my OCD here was the problem, the relationship that I had to this particular thought. I don't know if I'm articulating that well. Is that making sense?
It sounds like that could be what's happening, actually. But I find it, more effective to actually go into this fusion belief directly than having this exposure across different themes, because what you did, when I did CBT, it was like an ongoing, like onion layer. So then you had to expose them to that, then you had to expose them to blood, then it had to be bacteria. And then there was new topics all the time, and we had to start all over exposing. And I don't find that in metacognitive therapy because you get a direct hit. You get the direct hit straight away with the fusion belief. So you go straight into the fusion belief, and that makes the therapy shorter. And you don't have this jumping to different themes because they get an all-round restructuring of what is thoughts. And can they make me do things? No. Can they make me difference? No. Can they make things happen? No.
Right. Bronwyn, from an inference-based CBT perspective, it makes me think of feared possible self. And perhaps inference-based CBT, again, is an example of a metacognitive process. Kind of sounds like that is a piece of it. But I'm thinking of like feared possible selves, for example, and how if we have this feared possible self where we have this relationship, so that's what I would kind of think of as a core belief there, right? It may even fit into one of those three core beliefs that you were describing.
We're talking what kind of core beliefs are you talking there? Are you talking like a schema kind of belief? Because we're not working with schemas. They change from day to day. So we don't believe in this concept of schemas that are more stable. We don't think they are. They can become feeling of stable if you ruminate a lot or if you dwell a lot, then you can feel it's more like a stable, low self-esteem, for example, I'm not good enough. But it doesn't exist like a stable schema, but it's more the consequence of the CAS, of the cognitive attentional syndrome. So if you spend a lot of time thinking about I'm not good enough, then it will kind of feel like you have this core belief about not being good enough. But that's just a symptom, like heartbeat.
So where I'm trying to reconcile it, as I've learned in the last few years more about inference-based CBT, and Bronwyn, maybe you can kind of help me think with this, because that is a process of going, how did we come up to this reasoning error that is based in our imagination, not in reality, and what we can draw from that?
For me, like a schema, I'm a bad person. I'm a bad, like, wouldn't it be that kind of belief? I'm a bad person.
Feared possible self is going to be just through an I-CBT lens, it's the same thing as any other obsessional doubt. It's going to be a doubt that comes through a faulty reasoning process that's taking you away from reality and putting you in imagination, and that you're treating it as if it's reality. Where it sounds like with metacognitive therapy, you're actually looking at how your relationship with that thought, like how that is coming into your mind, and you're giving it credence as if that is you, right? And I know that there's a detached mindfulness piece to MCT where we're noticing that the thoughts are not us.
And you could, of course, ask, so if you let that thought be, if you didn't treat it, would anything bad happen? Would if you didn't make it go away, would that have consequences? Would it make you bad? I mean, not handling the thought, would that have consequences? And that would be that then you would get the fusion out, because people say, no, I can't leave it alone. If I leave it alone, I'll be even a worse person. It will change my who I am. So they have this. So if you ask them, so if you let that thought be, would any consequences happen? Then you have the fusion come out. And then, of course, you would realize that doesn't happen. So nothing.
And that was a big question I had for you, actually, as I was preparing for our conversation today. And, I mean, my OCD story is out everywhere, but I have lived experience with OCD. And so as I was reading through Wells's work and thinking through this, I was thinking about treatment readiness. And for people with OCD, to let the OCD go is so scary. So I wanted to ask you about that. Like, how do you help somebody with OCD get ready to take this information in?
Yeah. Well, first of all, we work with the fusions. And like I said before, that can take some of it away. So people get a more relaxed relationship to intrusions. So they realize this is normal. Everyone has intrusions. That's a surprise to many of my OCD patients. They say, well, you have, I think about killing my baby and everything like that. I'm really surprised. Do you have thoughts like that? Yes. So intrusions are normal. Everyone has them. And when they realize this, they might still hold on to the OCD, because in metacognitive belief and view, the OCD is actually only compulsions. So it's not the intrusions. That's what people believe. And we have, in the first treatment session, we have a case formulation, because the OCD patient comes in and said, well, my problem is my intrusions. If I didn't have my intrusions, I would be happy. So they have a different problem view that in the case formulation, we look at, is it the intrusions or is it how you treat them and how you see the intrusions? That's the real problem. So we get a different problem approach, a different problem formulation. And they realize, well, it might not be my intrusions. It might actually be my belief about my intrusions, what I believe about them, and my handling them, the compulsions. That might be the problem. And so we work on changing the view, the fusion restructuring. But even after that, people still do compulsions sometimes. So they will still do the washing of hands. They'll still do, mental rituals and things like that, even if they don't have the fusion beliefs. And that's when we work on the positive beliefs about rituals and thought handling in general. So that would be the usefulness of the cognitive attentional syndrome. And we do that. We put that into like a pro and cons. What are the benefits of doing all these compulsions? What are the costs? And then we do some behavioral experiments, testing out to completely leave the thoughts alone for just a week and see if it's getting worse or if it's actually self-regulating, because metacognitive therapy is also based on the hypothesis that thoughts and feelings self-regulate. So we test that out.
For some folks listening, and I run into this, I've looked in and chatted to with Dr. Michael Greenberg on his rumination-focused ERP work, and he draws a distinction between, and I have a feeling MCT will as well, between awareness of something and attention to something, right? And then further, even more, engagement with that something, right? The response to that. And so when you're thinking of the cognitive attention, can you help listeners understand, and even therapists, like what you mean by cognitive attention versus maybe just more broadly awareness that something's there? Because we're going to have awareness of these thoughts. And I think sometimes people conflate the two. They're like, but I had that. And so, right?
Yeah. So we actually, in metacognitive therapy, we work on this focused attention, and we have this lazy attention. I usually call it lazy attention. So we realize that it's possible to be lazy around a thought and a feeling. So detached mindfulness, where you just observe, is not being empty in your mind or not having no intrusions or being completely numb in your body. It's more observing the fire and waiting for it to kind of go out by itself. And that would be the lazy observed. So we observe it. It's like an awareness. Like we're aware of it, we can see it, but we don't try to fight it. We just observe it. Like I use some metaphors like a mosquito bite. You observe the mosquito bite, but you don't scratch it. You don't try to get rid of it. And that's what we practice in metacognitive therapy as the solution.
Yeah.
And then we have the focused attention. And it's very important that you don't, because the focused attention is a bit risky actually to put into other diagnoses than depression. Depression is not so risky, but if you put your attention to the left, put your attention to the right, you try to find the noise over there. If you introduce that in anxiety diagnosis, they sometimes use it as a new strategy. So it becomes a new attention strategy in like we just take the cognitive attention away, we just add another active strategy, moving attention around. So when they have an intrusion, they will say, oh, focus on the windows, or focus on, I have to, they start using this active attention as a new strategy. So really, we only use this focused attention primarily in depression, where they have this very low awareness. They're not aware of that rumination. It's like 4 hours later, they realize I've been ruminating for 4 hours, and they can't stop it if they don't realize they're ruminating. So the attention training, the more focused attention training, is helping the depressed patient getting more aware of their rumination process, helping them to stop in time.
Right.
But in OCD, they might use it as a new compulsion, a new strategy to handle thoughts.
Right.
So
Or distraction from it. Yeah.
So we're really a little bit stingy with the focused attention, or we only introduce it to depression usually. The other diagnoses get the more lazy attention, the pure detached mindfulness, where we practice observing thoughts and feelings and not engaging. That's the things we use for OCD, PTSD, generalized anxiety, and so on.
And the reality is we do this every day. When we're thinking about it with the diagnosis of OCD specifically, we do it in non-obsessional ways. Because, for example, right now, my attention is focused, for lack of a better word. Focused attention is here on this conversation. There's different things in my room and I'm aware they're here, but I'm not focusing or engaging attention with it. Yes, they exist. And I think sometimes people go, well, if I'm aware of the existence of it, and that has some meaning to it, which is kind of bringing us or circling us back to the greater point, is that we have some different ideas and relationships with these thoughts and the meaning and the value of them. And because of our belief system that weighs it out in one way or another, my belief system about the wall hanging not falling off the wall, which I wouldn't expect it to, isn't the same as the belief system where I'm afraid I might hurt my kid. Right. And so we respond to this one because this one feels so much more dire, but also, is it that different?
No, it's the same. But I think that, unfortunately, and I have been a part of the problem, cognitive therapy has really had a lot to say here, because we learn in cognitive therapy that thoughts are important. And I've been teaching my clients for the first 10 years, your thoughts are important, your negative thoughts, they're your schemas, we have to change them. Your thoughts will give you low self-esteem. And so cognitive therapy has demonized negative thoughts a little bit, and they are maybe part of the problem, actually, because people have taken this in and they think thoughts are important. So it's hard to distinguish. And that's what it makes, how it's so hard to do cognitive therapy for OCD now, because sometimes you say thoughts don't matter, but this thought is important. But that's a schema thought, and we have to restructure that one. So it's a bit of a mixed, I think it's more pure in metacognitive therapy. Thoughts don't matter. It doesn't matter if it's an intrusion thought, or if it's a negative thought about yourself, or if it's a schema-related thought. Thoughts are just thoughts. So it's a more pure message to the client.
Yeah. It reminds me too a little bit of, I was just talking with a colleague of ours, Carl Robbins, on anxiety sensitivity. And we were talking about it in kind of in the framework of whether we're thinking of heightened anxiety or panic disorder. And one of the big key pieces of the psychoeducation when you're dealing with panic disorder, even coming up with having heart palpitations and different things like that, it kind of reminded me of what you were talking about with that core value of danger, of like it's appraised that it's dangerous, right? And the reality is you're feeling these different things, but that doesn't equal the danger. It becomes hard, though, for folks then to sort out then what's a truly dangerous thought? When can I trust my instinct or my common sense? And when can I write it off and be like, well, that was just a thought and thoughts don't matter? Like it can be, and I'm not saying that in like a pushback. That's like, I think this is going to be a grappling for people to wrap their mind around. So what would you say to that?
I would say you never know. No one knows. Not even people without OCD knows if it's a thought they need to listen to or not. We never know. I don't know if the thought that pops up in my head is something I need to listen to or not. No one knows. So it's the same with people with health anxiety saying, but I don't know if I've got cancer. How do I know? And no one knows. I don't know if I have cancer. So it's not knowing that's the problem. It's what you do with the unknowing. So it's the handling still. So I would say it's normal not to know if this thought is something you need to listen to. If it's not, no one knows. But can you leave it alone until 5 o'clock? And maybe it becomes more clear if you don't spend 10 hours trying to find out if this is a thought you need to listen to or what you really want. Because spending 10 hours trying to find out will only make you more confused and will not get you closer to the answer. Not at all.
So
opposite.
So one of the more recent learnings, as I mentioned earlier, that I've been diving into, and I love this, by the way, I think the more options we have, the better, right? Because we don't have cures for things where our brains are braining in these different ways. Not everyone's going to respond to this treatment or that. And like you said, efficacy, even with MCT, efficacy is super high, which is awesome. But it's
not 100%.
But it's not 100%. So I love that there's an option here. But I'm just trying to think through it with my reference point basically being exposure and response prevention and inference-based CBT. In inference-based CBT, with that same scenario, if we wait till 5 o'clock and then address, was the handler needed? Was this, from an inference-based CBT perspective, we might actually conceptualize this as there was nothing to handle. It was more of a reasoning error in the specific slice of obsessional content. I kind of got pulled in to my imagination around this sequence here. And so resolving the reasoning error, resolving when I kind of stopped trusting myself, my instinct, my common sense, and kind of zoomed into my imagination, which this is a real broad brush sweep of I-CBT. There's so much to it. But that would be more of the situation where we would go, well, actually, I see the error. If I see the error in it, it's a con, it's a trick. I don't have to sit there and argue with it and even address the handler. What am I handling? I'm handling an imagined conclusion over here. And so we can choose not to engage. So that would be coming from the I-CBT framework. How would MCT differ from that?
I just have to ask you, so would you need to know if it's true or not, or if it's imaginary or not, to be able to leave it alone? Because we don't need to know that in metacognitive therapy. Do you need to know if it's imaginary or not to be able to leave it alone?
I think leave it alone is maybe not the way I would phrase it, but what I would say is a sorting of, do I have direct evidence here now that says, hey, maybe this is worth some effort and investment of your time and energy versus not? Is this something happening right here, right now, because I can see a mole and that might be cancer? Or is this the idea that I have moles, people with moles, it can turn into cancer. It could be cancer, and I'm kind of zooming ahead.
So you're more talking about realistic thinking, but But the problem is people are not aware if it's this realistic or not. They have this unsureness. So they get this, is this mold something I need to go to the doctor with or not? So they have this, the trigger thought is I don't know. I don't know if this is cancer or not. And so, yeah. And so they need to kind of leave it alone, because if they start, oh, is it cancer? Is it not cancer? And then to spend 10 hours, they'll get health anxiety. That's for sure. And so we don't really know. We don't need to know, really. We make a decision about strategy, call the doctor, not call the doctor. And so we don't need to have realistic thinking in order to be able to leave it alone. That's the uncontrollability belief, that you think you can only leave it alone if you know it's not cancer. But you can even leave it alone without the knowing. So even if you don't know if it's cancer or not, you can still leave it alone. And even if it is cancer, I wouldn't suggest 10 hours of worrying.
Right.
Because you would just waste the last 14 days of your life worrying. That wouldn't be useful at all. So even if you know it's cancer and you call the doctor, you still need to leave the thought alone, even if it's realistic. So we would actually suggest leaving it alone, not knowing if it's cancer or not. I mean, the unknowing, we don't need to have realistic thinking to be able to be detached, to use detached mindfulness.
Yeah.
Your question about the differences also, I mean, what is the goal of metacognitive therapy? And that is the ability to leave everything alone, even if you know it's true. Even if you don't know it's true, even if you know your boyfriend is unfaithful, can you still leave it alone? Because it won't make him not unfaithful to worry 10 hours a day. So you can't even have a better boss. Even if he is a bad boss, you can't make him a good boss by worrying about how bad he is 10 hours a day.
Yeah. So it all comes back to that belief of the function of worry or the function of doubting and
uncontrollability.
Yeah, it's not going to add to your life by continuing to stay in that content. Instead, you can look at your belief system about the value of worry and start to notice that, okay, I don't have to value worrying. I can step away from this. I'm not going to solve anything while I'm in it.
It's the last metacognitive beliefs, the usefulness. It's not useful to handle my thoughts, my compulsions. They just work on the short term. So we have this usefulness and we have the uncontrollability. And that is, I can leave thoughts alone independent if they are true or not. I don't need to know. I can even know they're true. I cannot know. I'm able to leave them alone and only spend half an hour a day. And then, of course, the danger belief. Worrying is not dangerous. The stress I get from worrying will not kill me. It's completely harmless to worry. And the thoughts are normal. The intrusions are completely harmless, very normal. So that's the goal of metacognitive therapy, to get that restructuring of the three metacognitive beliefs.
So if someone did actually have like a realistic thing going on, let's say they did have cancer, metacognitive therapy wouldn't say, hey, you don't ever have to think about it again. That's going to solve your problem. It's don't ruminate about it, because that's not going to solve the problem. That when there's an action step to take, you're going to step in and do it. But you don't have to sit and think about it all the time, because that's what's going to cause you more pain.
Correct. I think a lot of people confuse worrying with action, and it's not the same. You can do a lot of actions without the worrying part. It's not the same. You could be, handle your life without thinking so much.
Yeah, okay. I think I'm getting there. So part of me at first, and I had to leave it alone because I really wanted to be able to listen to what you were saying and not just kind of construct kind of my understanding of it. But it sounds like in the similarities, because part of me is like, okay, but in thinking about I-CBT, but, and then I had this kind of aha moment for myself where I was like, this is kind of like debating whether technique or is this a compulsion or not, and getting kind of zoomed into the process of a different subtype or whatever within OCD, because I'm missing the point if I'm zoomed in that much, because I'm looking at kind of how this model functions and that model functions. And really we're saying how model functions, it's how it functions. But we need to kind of even go one layer back and go, what is our belief? What is our understanding, our appraisal to what we think about the broader functioning and how that is somewhat engaging with whether it's ruminating or compulsing or avoiding? How is that engaging with the mental health disorder? I think, I don't know. I have it like halfway there, I think. I show my work in how I thinking through it too, Pia, by the way, because I think sometimes it helps disarm the trickiness of these meaty concepts when people are like, am I supposed to be getting this? Because I don't yet. And yet is the operative word. And so we're looking at that relationship. Maybe that's the better word, the relationship to how we're appraising our thoughts. And
Yeah.
we're saying, actually, we don't have to think about our thoughts in that way.
No, exactly. So it's possible to leave them alone, and you don't need to get rid of them with your compulsions, because the difference is between normal actions and compulsions is that when you check the door and you don't have OCD, you look at the door, it's locked. But if you do it as an OCD, you check it until the thought and emotion of doubt is gone. So it's a different way of action is different because it's based on the stop signal is different. So the stop signal is getting rid of thoughts and uncomfortable feelings in OCD. Whereas when you check the door as a non-OCD, you just check the door and you have an external stop signal. It looks locked, it looks closed, and you move away. So it's more like an internal stop signal. My thought is gone. Everything's good because the thought is gone, and then I'm safe. The door is closed when the thought is gone. So that's an event fusion that you think, if I have the doubt about the door, then it's still unlocked. So I need to get rid of the doubt, then I have a locked door. Whereas the non-OCD don't think about emotions like that and thoughts like that. They just say, well, it looks locked, so it's locked, and I move away. Even if they get doubt is locked, they leave it alone.
Yeah.
This fusion belief that doubt equals real. It's real. So we have a doubt. That's like a thought event fusion. If I doubt something, then it's happened or it will happen.
Okay. I think I'm getting it.
Mm-hmm.
Bronwyn, little check. How are you doing, my co-pilot? Is it making sense, settling? Are there any questions bubbling up for you?
Yeah, I mean, I'm very new to metacognitive therapy, so I'm just learning along the way, especially gearing up to Pia coming to do a training. So I'm really excited to learn this more in depth, and I'm sure we're gonna be able to get into this conversation. And keeping the lens on OCD, what I'm hearing is the compulsions, that stop signal, which I'm very familiar with, of hand washing for hours at a time. So you're washing, and then you get to this place where finally it feels okay. And that's that stop signal that OCD is giving. And metacognitive therapy would say that stop signal is meaningless, that you're using that to gauge reality here, but that it's not. It has nothing to do with that.
No, it's a CAS strategy. It's a cognitive attentional strategy. It's nothing more than that. And it doesn't have any benefits, and you can't save the baby. You can't save your house by getting this stop signal is meaningless, like you say.
Right.
That's part of the behavioral experiments that you do in the treatment, of course, to realize that.
Yeah. And so what's happened to cause that to happen over time, though, is that the person is believing that they need to wait for that particular signal.
So what we do is we try to go away from the door with the wrong feeling. So what we have is actually holding on to the thought. So they can do the ritual, they can try to do kind of lock the door, but they need to hold on to the thought. The door is still unlocked. The door is still unlocked. The door is unlocked. And they need to hold on to that. And then the ritual becomes meaningless, of course, because the function of the ritual is to get rid of the thought. And when you had to hold on to it, kind of messes up completely the OCD. And that's a specific metacognitive strategy, actually, to hold on. I don't believe that is what you do in cognitive therapy, to kind of continue the ritual, but holding on to the thought and realizing the ritual is useless because it doesn't work. You can't get rid of the thought if you have to hold on to it, completely messing up the OCD then.
Yeah.
Right.
The door doesn't happen. And then you get double up. You get the fusion restructuring because you walk away with the door, holding on to the door is unlocked the whole day. And then when you come home in the evening, you had it 50 times, the door is unlocked. And then you have a fusion experiment because you go home and the door was locked. And so you get the evidence that thoughts don't make things happen. So you actually restructure your fusion belief too, and also mess up the compulsions at the same time.
Okay. So I'm confused. And I'm like, because every time I'm like, oh, but and I can, and I know myself pretty well. So I can say like 9 times out of 10, which is really like 12 times out of 10, beyond the ability. I'm too zoomed in. And so I'm trying to zoom out. I think that's probably my issue, that I'm getting too sucked into some of the details that isn't where it's at. So what I'm wondering is, can we maybe even set up a vignette? Maybe I could play client and you could be therapist and you could walk us through, because I do try creating that cognitive feedback loop for the risk of being cognitive here, but I typically do an application segment for the family. And I'm like, okay, I think I'm missing the mark because I'm so zoomed in. I'm not seeing the forest through the trees. So I'd be happy to play the client if you would be okay with maybe role playing.
So which session is this? Is it like the case formulation session where we
I
kind of
have,
go
sure,
your
case formulation session would be great because
I would do the case formulation lesson because that's at the beginning.
Bronwyn was like, let's start at the beginning. A very good place to start, Bronwyn.
But I would ask for the last time when you had an intrusion, and would that be today? And I would have like a slow motion analysis of when you had the intrusion. Was it yesterday or today?
I have lived experience and I feel like I can commit to this role as client, and we can even use the door lock example. So if I were to come in and I'm like, okay, listen, Pia, here's my problem. Okay. Let me just lay it out for you.
Tell me about your last intrusion. When was the last time you had
Well, coming here, because I am clearly coming to your office across the world. What a commute, first of all. But I went to leave the house. I grabbed my keys. I closed the door, and I know that I need to lock it because crime is up in the area. And honestly, I don't have like money to replace everything, but also like I feel really anxious about that. And so I locked the door. But the reason I'm late to your office today is because I have to go back because I don't know that the door was locked. And again, like there's a lot riding on that.
So how long time did you do this for? How long time did you move back and forth to the door?
Oh my gosh, what time is it? It's, 7 after. So I'd say like, I don't know, 3 hours.
3 hours. So why didn't you do it 5 hours? What stopped you at 3 hours? What was your stop
I
signal
didn't
at
want
3
you
hours?
to be mad at me. We had an appointment that was supposed to start 30 minutes ago.
But okay, so it was because you thought, okay, now I have to. So did you feel better or worse after the 3 hours, or did you just feel the same?
Like it still might be unlocked 8.5 hours late.
Yeah, it's this is double crap. Yes,
Double crap.
tell me a little bit about having this thought and trying. So tell me a little bit. So do you think if I gave you a little crazy experiment, you had to hold on to that thought a lot? Do you think that would increase the risk or not about your door being unlocked if you had to kind of
If I had to hold on to the thought that it might not be locked,
would that kind of be playing with the fire a bit, or would you think, I could do that?
I mean, I can do it. That's been my life for the last, 7 years.
When was last time you hold on to it and tested it? I mean, did you try to get rid of the thought, or do you try to enhance it? What do you normally do?
Well, I try to lock my door.
But you said 3 hours and then you move. What would be? I mean, did you manage to get rid of the thought or not?
So eventually, yeah, I do think about something else. But what happens is, well, I could be, here, and I'm obviously thinking about it right now because we're talking about it, but it will either pop into my head at random times, or I'll drive home and I'll have like the sense of dread kind of fill, and I'm like, oh my gosh, did I lock it? Is there gonna be somebody in the flat or the apartment? It's a mess.
What would you normally do with the thought when it pops up? What do you normally do with it?
With that specific thought or just any thought?
Well, that intrusion thought.
I get anxious
Yeah.
because bad stuff will happen if I accidentally it could happen, I guess. I mean, theoretically could happen, but there's,
Worrying when you get the thought. Do you worry?
Oh, yeah. I worry. I am a pro worrier.
Do you do other things than worrying, or that's the main approach to
mean,
the thought?
That is one of my main resume descriptors, probably professional worrier. But I also sometimes like to go for a run.
Okay.
Is that the question you're asking?
But the question would be, how do you try to control your mind? What's your mind control strategies?
Well, I try to reassure myself. You know what, Nicole, you somehow got a master's degree and have managed to keep little humans alive. So you close that door. And then I go back and I check it and it is really locked. So that kind of helps me know like it could be locked. And then I kind of stare at it. I have this stare. It's actually kind of a ritual where I stare up and then I stare down and then I stare up again. That seems to help, especially if I do it in threes. And what else do I do? Sometimes I just don't go home because I don't even want to, or I don't leave the house. Actually, that's probably better kind of idea of it, because if I don't leave the house, I have to. I know it's locked on the inside. I know that might sound crazy, Pia, but I can tell it's locked on the inside. It's only when I'm outside. So if I don't leave, then I don't have to even start the whole cycle. It's so exhausting.
But it sounds like a lot of worrying, trying to suppress, trying to reassure yourself, trying to talk to yourself. And has it solved the problem in the long run?
No.
Has it? So it's the same, worse, better, same, hasn't done anything.
Might I reason it's gotten worse over the years?
Problem worse. Okay, so let's have a look at this model, and I will show you the model. And I'll have put into your intrusion would be the door is unlocked, and then you have this fusion belief. I need to reassure myself. I have to get rid of this thought. I have to feel calm otherwise it's true. It will be unlocked. And so you start worrying and handling and checking and all this, and that's just a vicious circle.
Yes,
So
you get me, Pia.
So let me ask you, if you didn't believe that this thought was important, what would happen? If you somehow realized this thought is completely like, milk in the fridge, there's sunshine. If you thought this thought is not important, what would happen? If you realize that?
Well, honorable mention that it does feel very important. So if it was like the sky's blue, the sun is shining, or all of that, then it'd be like, okay, and?
Okay, so do you think your problem is having those thoughts, or do you think the problem is your relationship to the thought, that you believe these thoughts are dangerous and needs to be handled and you had to get rid of the thought and that makes you spend 4 hours on it? What do you think is the main problem here?
I mean, I see, but Facebook stories were saying how the block over, this is dangerous. So how is that the same as milk in the fridge?
Yeah, so there's a lot of, how do you know you worry about the right thing though? Because like you said, there's rape, there's cancer, so how do you know that this thought represents the real danger? Do you know?
The question of my life.
We have asbestos and we have so many thousands of things you can die from. It's incredible. So do you still think it's the theme, the object level theme, the unlocked door? Or do you think it's that you give this thought a special attention? Because like you said, there's so many things to die from and there's so many things that can go wrong. So how, like we said, we don't know if this thought, just because it pops up, is the real danger. It could be thousands of other things going bad.
Well, I do see your point that why is my brain latching onto that? Because there's lots of things that could happen. And so what you're saying, if I'm understanding it correctly, is maybe it's not that it is or isn't, like that there are or aren't robberies happening in the neighborhood, that there is or isn't, a possibility of something going wrong even if the door is unlocked. But it's the way did you say relationship to the thought? My relationship to the thought is that this is going to be the end all be all.
Like, so if I have this thought, this is what's going to happen. But all the other things, the other thoughts you didn't have, they might happen. Has anything bad happened that you never had a thought of? Like, well, you don't know if the existence of the thought represents the real danger. So if you didn't believe that, if you thought that was just a thought, it doesn't represent the real danger. Well, it does, maybe it doesn't. It's just a catastrophe thoughts, like there's so many of them. Yeah. What would your life look like if you didn't put special meaning into that specific catastrophe thought?
You know what's interesting is, as you're saying that, I'm realizing I didn't think I thought that just the existence of a thought was that powerful, but I guess that is kind of what's happening around the thing with the door, because I'm like, well, of course, yeah, all sorts of things exist. That's not what I worry about. And then I thought, okay, so why this one? Because I haven't had anybody actually break in. I've never, that I realize. I'm sure it's happened, but it hasn't obviously ended in the big bad terrible something, left the door unlocked.
So let's move on to because we don't want to stick into this reassurance. We don't want to have too much reassurance talk. We want to move on to,
I love reassurance.
We want to go to the action now, because otherwise it would be like more reassurance about nothing.
Fair. You guide me, Pia. I trust you.
I will stop you there and say, well, let's move on to getting a new relationship to the thought. Let's see if we can. So do you think, you say that have you ever tried not to reassure yourself, but to hold on to it and see if this bad thing happened? Have you ever tested if not handling the thought will actually make it happen? Have you ever tried to leave the thought alone and realized I had a robbery? That was a bad thing. I mean, if you didn't handle the thought, have you ever tried that?
So what you mean is, have I done like trial and error and like intentionally left the door unlocked and been like, yep, got robbed for sure.
Well, no, not leaving the door unlocked, but leaving the thought alone. Like you wait 10 minutes, you just, lock the door and then you move away with the doubt, with the thoughts. Maybe it's not unlocked. It's definitely not unlocked. Maybe it's not unlocked. You need to go back and not handling that doubt. Have you ever tried to leave the doubt alone?
Well, funny you
in your mind?
should ask, because I don't feel like I can not handle it. It's like boom, 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 like popcorn exploding in my head. That's probably not the right way of saying it, but it is popping. It's popping. But you're saying, have I ever tried to not pop it?
Like we have this little exercise in Metacognitive Therapy where I throw some paper balls and then it's like the popcorn in your mind. And in the first round, you kind of fight the popcorn, you fight the balls. You can't try to get rid of them away, try to, handle them. And then you see how stressful that is and how draining it is. And you're completely tired after 10 minutes, 10 seconds, you are really tired. And then we try another round. I throw the balls, like your popcorn mind. And then you observe, just observe the flow of thought and you don't fight them. Have you ever tried that with your thoughts?
No, but I like the imagery of that. I am connecting to that. No, I do think that it would feel a lot less stressful. Like you might have an initial kind of impact of whatever balls hit you, but again, it's kind of harmless and you're not getting stressed out.
Or you wouldn't be as tired, that's for sure. You still have the thoughts, you still have the uncomfortability, you still have the anxiety, you still have the tension and so on, but not fighting it and not trying to reassure yourself and going back and checking and so on would give you energy and more time. That's for sure.
Right.
And try it out. And see if leaving the thought alone is dangerous. So that would be the fusion restructuring. On controllability, is it possible to leave a lot of thoughts alone? That would be on controllability. Can you do it? And then, of course, usefulness. It wasn't useful. It's a waste of time. It doesn't stop bad things from happening. So, for the 3 levels, 3 metacognitive.
Is the idea then that the brain will get bored at a certain level if it's not useful? If it's like, and it sees like it's not dangerous and it's not
Doesn't
like
need
your
to
brain just is like, next.
leave it alone.
Okay. And seeing.
That's practical. So I would do the popcorn, the paper balls, but we can also practice with me saying words like unlock door, rubbers. I would say words, and then we practice leaving the associations alone. So you'd get images. So if I say robbery, you'd get an image, and we practice being lazy towards those associations that will pop up. And not practice, not paper balls, but this time it's imagery that we leave alone.
Yeah. That helps me a lot in understanding it a little bit better because I was having a hard time with knowing how to leave it alone. But I think even like the visual, or I would imagine even like in a session having the paper balls hit you and not, you'd be like, there's clearly a difference, right?
Little difference because you still have the impact. You can still feel the thoughts. You can still feel it. But fighting and being lazy is a huge difference from how tired you are and the stress level and how draining you feel afterwards and so on.
Yeah. Passive versus active response, really.
We practice a lot of lazy response to thoughts and feelings. And then in OCD, we also sometimes hold on to the intrusions just to see that nothing happens still, even if we hold on to them, like playing with fire a bit, and then really see that nothing bad happened because that's really powerful restructuring of these fusion beliefs if you do these experiments holding on to thoughts. So that's not leaving it alone. That's not so lazy, but it's like a short-term experiments. In some of the first sessions, we do this to be more able to leave the thoughts alone in the long run.
So would that be like, even in the imagery of throwing the ball experiment, would that be like, and now I want you to catch the balls, pick them up and hold them and like be intentional about thinking about that. And then in 10 minutes, did that change the outcome?
It's a bit more. So in this way, testing would be like holding on to, I'm robbed, and then seeing that you don't get robbed, even if you really enhance the thoughts. But that's really like a powerful thought fusion test. And then when you see this, then the fusion completely, dissolves. And you are much more able to be detached and leave these intrusions alone because you know that they are harmless after this experiment.
Yeah.
Yeah, do you do a lot of like when you're working with the fusion beliefs, do you ever do experiments with things within OCD where the person doesn't have any fusion, but you're doing it as an example of, see, you don't think that this likelihood is going to happen when you hold this thought. So if I didn't have OCD around sexual orientation, for instance, and I thought, okay, maybe my sexual orientation, I don't really know my sexual orientation. I hold that in my mind. And then I'm anticipating if I really am believing that I can control the likelihood of something with just my thoughts, and I don't buy into this particular OCD intrusion or doubt, that I can see that I'm not going to change. I don't believe that I'm going to change the likelihood of that happening there. And then you can transfer that over to somebody's actual doubt where they have that thought of
Yeah.
it fusion happening.
Yeah, exactly. Yeah, exactly. That's what we do. So if it's more like sexual intrusions and people are afraid of the sexual intrusions, we will test it out. But it's too difficult for people to start straight on with a homosexual intrusion. So we need to start with something like, do you think you can change other things that you prefer in your life by thoughts alone? So if this thought can make you homosexual, if the thoughts can change your sexuality, they might also change your political orientation, or they might change your preference for food.
Right. Yeah. I was thinking food. That's a good one to do.
So we would try to make you hate chocolate like, I hate chocolate. And after the week, do you hate chocolate? And then that would be like the first, thought fusion experiments. And then we'll move on to eventually homosexual thoughts and see if you, after a week, become homosexual, for example. So we don't go straight into the most powerful intrusion because people find that bit too difficult, actually.
Right.
So,
Right. The scaffolding in it. Yeah.
Even exposure in CBT is also gradual exposure, isn't it? But this is not exposure. This is more like testing thoughts in different, because people have, the more emotional the thought is, the more dangerous it is. So the fusion grows with emotions. So if it's, I hate chocolate, they can do that. But then it's more like, I hate my girlfriend. Okay, I can do that. But then, I'm homosexual. Oh, it's more, it's got a lot of emotion on it. And they think really the fusion is on now. That's a dangerous thought if it's really emotional.
Yeah, I was thinking similarly, like when we set up hierarchies in ERP, that is absolutely the mindful kind of direction that we're going. Like we're gonna take a toe and then we're gonna put a foot in and we're gonna kind of wade in. We're not just cannonballing into this. And that way, the practice of the skill. And often what we find is partway through, then again, like, gosh, some of this is like, oh, actually, I'm good. I'm good. Like that relationship with even that certain thought that in that scenario kind of comes as an after effect has changed for me. My awareness of it has changed. My reasoning around that can change, and it can kind of feel like this concrete flip of the switch. Yeah, it's interesting to think about just even the process. I feel like I'm getting maybe a little latched on the difference between the exposure and kind of the engagement in the direct thought of I'm a murderer, I'm a murderer, I'm a murderer, for example, and holding that for 10 minutes or 5 hours or however long, right? Because that again, and the function of it, I think is different, and I'm probably getting too zoomed in.
Probably getting the same effect. That's why CBT is so effective. But the primary goal of these two interventions are very different. I mean, the primary goals are different. So in classical exposure, your goal is to kind of kill the emotion. You're killing the tension. So when I did CBT, I would ask people to, do disgusting things until the anxiety had gone away. So we would go to the toilet, not wash hands. So you would ask people to like hold on to a thought until they didn't feel anything anymore. So it'd be like a habituation. It would need to kill the thought or kill the emotion. But the primary goal of MCT is not to kill any emotion, kill any thought. So you'd still have intrusions after you are cured or you are recovered in MCT. You still have intrusions. So you're not killing the thought, and you still have emotions. You still feel anxiety, and you not even still feel it's an uncomfortable thought. This homosexual thought is really uncomfortable, or this killing my children is not a nice thought. You still have emotions. So it's not habituation in MCT. That's the primary goal. Might be a secondary one because people find that they don't know. But it's not the primary goal. And so the primary goal of MCT is getting a new relationship to your thoughts and restructuring the metacognitive beliefs. So it's like the two primary goals, and you might have the same like endpoint. People that don't have OCD anymore, they're not. But it's not the primary goals of there's very different primary goals.
Right.
Habituation situation, and metacognitive restructuring is two primary goals.
Right. Yeah. And so really good two different levels of the process of like, because one is the direct result of engaging in the thought, and the other one is really looking at the function, if I'm getting this correctly, if I'm not correct.
Like I said, there's an interaction here. So you
Yeah.
with the exposure, you get the metacognitive restructuring as a bonus effect. And if you do the restructuring, you get the exposure effect as a bonus because people feel more relaxed. They don't feel so much anxiety anymore. So you get this, like it's more like what's primary and what's secondary. And so there is an interaction here, and people get better in both treatments. They end up feeling better, but you have a different, it's a different model. It's based on different theories about the mind and theories about the cause and solutions of OCD.
Yeah. So one is getting caught up in the thoughts and feelings that these obsessive inferences of doubt can bring up for us, these intrusions, for lack of a better word. And the other one is more of our thoughts and feelings about the thoughts and feelings we get about these intrusions or inferences of doubt. And so in the example that we did, I was saying, yeah, I did actually have, even though it's not my thing, right, about locking the door, I did have that moment where I'm like, why is it like this random one over here? Like the relationship to that. And yes, whether it's circulated on Facebook, there's all sorts of shit circulated on Facebook. Like, and so realizing like, oh, it's the feeling now this feels really important and the belief that that's really important. Now I'm engaging in it. And so it's less about, absolutely less about getting into the content of any of that and staying at the why the belief here versus, any other given belief. Like almost like you've chosen to give it this meaning. Why? You don't have to.
Yeah, exactly. And you can even leave it alone if you don't know. So you don't need to be sure. It's just a thought. You could just even then leave it alone. It's controllable what you do with it either way. And also, I would say MCT is really manualized. What you see in the research and the different trials is exactly what you see in real life because it's a session by session. Like when you see the complete cookbook, nearly like baking a cake, you know exactly what to do in the first session, exactly what to do in the second session, and so on. You get these amazing results post-treatment. So people will be recovered post-treatment, and they will keep the recovery at 6 months follow-up.
And MCT is 8 to 12 sessions usually, somewhere in there.
And very structural.
Yeah. So what I'm hearing, to create a full circle moment, because I love those, Pia, just FYI, is that almost like the Smearbrel, right? There's a construction to it, and people can just slap things together and make a tartine. That's not the same. It's not. She's like, no. So MCT has the guidance, the recipe, the how to layer it.
I think it's funny to think about how learning metacognitive therapy seems difficult, right? It seems heady. It seems like just big, right? But it is so structured. Like when you look at the treatment plans, it's here step A, step B, step C. And that is so funny to me.
He's a very, structured British man and a professor, and he really, his goal is to, because what he thought about with CBT, you don't really know what you're getting, because if you get a CBT therapist, is he more like compassion focused? Is it more like a mindfulness CBT person? And so we don't know if the results you get in the research can be transferred into real life. How do you know that you're getting what you see in the research trials in real life therapy? You don't know. And in CBT, everything has become big. It's a huge mix. It's schemas, it's compassion, it's emotion focused. It's a whole family of different approaches that you put in this toolbox, and you don't know what you're getting when you seek a CBT therapist. And this is really what Adrian Wells wants to get. He has a different vision. So his vision is that you know what you're getting. So if you're getting a registered metacognitive therapist who's had this 2-year program, you know exactly what you're getting. You can reproduce the results you get in research in real life, because in real life you get the same treatment manual as you will get in the treatment sessions in your research trials. So the 74% recovery rate in depression can be replicated in real life. And that's just his goal.
Yeah, it is. It's interesting because, CBT really kind of zooms in, and even if you're trained or specialized kind of in a certain area, it varies a bit on the nuancing experience, practice of the clinician doing it. So we may be working and trying to work from the fidelity of a certain model, but it kind of shifts and changes based on who's applying it. And you're saying with MCT, it should be the same no matter what. Like it should be across the board. We're batting off these paper balls, these thoughts, or we're not. And I think so many of us, even if we're treating, I'll just speak for myself, but if we're treating, we zoom so in because we want to make sure we get the fidelity of the model right. And as a lived experience person with OCD, you zoom in because it feels like if you don't, the consequences could be dire. So you zoom in, right? And so it's really this process of going, okay, but how and why are we thinking? What's the pattern that's kind of presenting itself almost around these different sticky thoughts, these different obsessional thoughts? When it comes to OCD, or if we look in different disorders, then it's, but again, like kind of looking at that process.
So it's like little bricks, little Lego bricks. So you have this case formulation, then you have the socialization, then you have the introduction to detached mindfulness, and you have restructuring of metacognitive beliefs relevant for the diagnosis, and then you have relapse prevention. So you have these bricks on top of each other, and they are really, like little packages nearly. You get a little package, and then you get another package, and you get another one. Very structured.
It is amazing to think of how many thoughts we have every day, and that those of us with OCD only have that process happening with a finite number of them. And so the way we interact with all the other thoughts and we're able to let them go, and our beliefs about those thoughts and our place in our lives are very different than the ones we have about OCD. And so this is a very interesting take on looking at that process of our relationship with those thoughts with OCD or depression or generalized anxiety or trauma memories and post-traumatic stuff. It's very interesting.
Yeah. Wow. Well, this has been fantastic, Pia and family. We've covered just kind of a slice, like not even skimming the surface of metacognitive therapy, because there's only so much that can be done in this sort of time block. But Pia, you are going to be presenting on metacognitive therapy for OCD Training School, and that is a live training coming up in February, end of February. And so would love to hear, and I know that you participate in different podcasts in your area, any and or all books, all the things you could recommend. And of course, we'll have that available for you guys to check out over at ocdfamilypodcast.com on this episode's blog. But would love to hear anything that people can follow along and learn more about this. What are some good ways to do so?
Well, one of the good resources is the Live More, Think Less book, an introduction to metacognitive therapy for low mood and depression. And that's a really good introduction to metacognitive therapy. And of course, joining the workshop in February, where I'll be introducing these blocks, these little packages I was been talking about, and see how you can actually transdiagnostically treat different diagnoses with these different blocks that I'm going to introduce.
Love that. Love that. And then, of course, the book that we've been seeing you guys holding up and all of that. Yes.
Partly for lay people, but for therapists, this is a really good one to go to, because you have all the different manuals in the back.
Yes. So that's Metacognitive Therapy for Anxiety and Depression by Wells. And again, I'm going to have all these different resources linked. Bronwyn, is there anything that you would add?
I think as somebody with lived experience and also as an OCD specialist who also specializes in treating PTSD, I'm really excited just to always have treatment options. This is an intriguing one because of the transdiagnostic element, especially to me, being able to help clients be able to handle multiple situations that have been going on in their life. And through an MCT lens, it would be the same process. But for those who are experiencing it can feel different. And so I'm excited to have another tool in my toolbox as I engage in learning and continue learning. I'm excited.
I'll say another toolbox. I wouldn't add it to an existing cognitive toolbox, but you get a new toolbox, a new metacognitive toolbox.
Another toolbox.
Right. Yes. And that's such a great point because, again, I think there's such a desire to be able to integrate and have these multifunctional tools that can kind of be a jack of all trades. And it's like, no, these are very different tools. And thank goodness, okay? Because for some people, CBT is going to be great. It's going to hit, it's going to make sense. It's going to bring health and recovery. It's going to help For some people, that's going to be MCT. And based on the research and the outcomes, that's a very significant portion can be from MCT. But we need different toolboxes.
Well, cautious with mixing or making our own little cocktails. We have to be really, really cautious. There are some studies showing that if you mix CBT and MCT for social anxiety, you can actually worsen people in their anxiety symptoms. So we need to, I mean, therapy is not harmless. It's not completely harmless. We need to be really careful with what methods we mix with what methods, because we can actually make people worse if we mix the unintegratable methods with each other.
That brings back the great point, because I think so often the temptation is to become mixologists, and it feels like we can offer more if we're mixologists. And really, it's like, no, let's keep it simple and really understand how these tools are used. And if we're going to learn MCT as a tool, then learn MCT as a tool, not try to fit a round peg into a square hole. We don't need to do that, right? We can learn MCT for MCT purposes. We can learn CBT for CBT purposes. And I think it just points to the benefit. If you want to know more, yeah, you can check out the intro book, all that, but check out the workshop. Check out some of these trainings. Check out ways that you can build your competency to be like, yeah, I am making sure that when I say I can offer MCT, that I actually know what I'm doing, that I'm using those bricks and building it up and giving my client or patient that 80% chance that this can be better, no matter the diagnosis. And I love that. And so thank you so much for your time, Pia. This was great.
You reminded me.
Yes. And Bronwyn, thank you for joining and helping me think through this.
I was still learning too, so I'm at the beginning, but I'm very pleased to be here and getting to listen to
Really
the talk.
to bring this to America, because as far as I know, there are no trained metacognitive therapists in the United States. They're all in Norway, Germany, Denmark. It's a European phenomenon. It's not come to the United States, and normally you are the first movers. So it's really exciting for us Europeans that we are the first movers this time.
Americans are like stroking their hand. They're like, we like to think we're first movers on everything.
On other things, you know.
And that's great for those of you listening, like the audience, for those of you with OCD, this is the exciting piece, is that we have options. I mean, ERP is amazing. It saves lives. It's great. And ACT can be such a great adjunct to ERP, and it has a lot to say even on its own. And inference-based CBT happened to be the thing that helped me, and I'm so grateful for it. And now having metacognitive adding in, like, to yet another thing, another toolbox, like Pia said, like we have these treatment options and medication. Like there's more things coming, and that's great. That's great for our family, right?
Absolutely, which is why we're featuring this during OCD Awareness Month, because the reality is, whether we get it or not, and I have a feeling, I might be wrong, Bronwyn, I felt this way a little bit around I-CBT, but Pia, I wonder if you find people that have never done therapy before aren't zoomed in to all these other details of other therapy models. So for them, it's not as hard to click with. They're like, that makes sense. It's us that have like learned all these other manualized models and protocols that we're like, what? But your average person coming in, it's like, yeah, that would make sense if they're not zoomed into these different details already.
It usually does. Yeah.
Yep. She's like, true. All right. I love it. Pia, thank you so much for your time. Bronwyn, thank you so much for your time. And family, thank you for joining us. Thank you for your time, because hope is on the horizon. Hope is on the menu. We've got a cookbook, and hope is on the menu. And if you want to learn more about MCT, which I guess I should ask, this workshop coming up is mainly for clinicians, not for just lived experience.
Yeah, we've decided to keep this one to clinicians for now, and we'll see what the interest is, and maybe there'll be more things coming from Pia and the crew in Copenhagen.
But look to our European neighbors that have already been doing this work. And you said you've been with MCT for 12 years now, Pia? Yeah.
And we actually doing research on different, with like autism and metacognitive therapy. We have one on insomnia and metacognitive therapy coming out. And I had an article on bipolar disorder. And it's actually working on all these, and it's really exciting that we're trying it out on anorexia, and it's showing so good results. It's really showing these 80% recovery rates across the board. It's really exciting.
That is exciting. Oh, and so thank you again, ladies and fam. Check it all out.
Intrusive Thoughts.
All right, fam. Wasn't that interesting? So fascinating. And you know what's also really interesting to me is I'm getting to learn along with you. And I have to be honest, even in revisiting the conversation today, fam, it gelled so much more. So thanks for taking the time to get a slice of this MCT cake, to use our cookbook analogy from earlier. But it really is just a slice. So if you want to learn more, check out the course or the books or even some of the other pods on which Pia has shared about MCT, because with an efficacy rate of upwards 80%, this is worth our while. And so for today's Intrusive Thought segment, which is the application segment of the show for any newer family joining, I want us to think about what Pia was sharing about earlier. Everyone has intrusions, right? And we also talked about how that uncontrollability belief is a huge antagonist in OCD. Feels like we don't have a choice, or our loved ones believe that these thoughts are dangerous. So often when living with OCD, we're reacting to the struggle, right? We're wrestling, we're ruminating, we're avoiding. So my question to you is to ask yourself, or to think with your loved one, what is my belief here? If you can figure out maybe you're experiencing thought-action fusion or something else, amazing. But it doesn't even have to go that deep. I'm merely asking, why am I swatting at these paper balls here and not over there? Because lots of things are flying at us in life. Lots of things with which we don't choose to engage. Why is it the door lock or harm or fear here or there that's tripping me up? Being curious, why do I engage with these balls? Why do I not choose to worry with these other ones? That awareness about that belief, the way we're thinking about our thinking. That's the little application that I want you to challenge yourself to today. Because what if OCD awareness is just that? I mean, it could be. Now there's a feeling I can get behind. Thank you for joining me and our OCD family community. If you enjoyed what you heard today, please like and subscribe to the OCD Family Podcast wherever you enjoy your podcasts. Did you find this content helpful? Please consider leaving a review. The more people that know they're not alone, the better. For more information regarding today's podcast, please visit OCDFamilyPodcast.com and remember to join the email list while you're there. It will provide you with the most up-to-date information, resources, and the down low on the family chatter. Oh yeah, nothing says family like Pia, Bronwyn, and me talking about MCT. That's right, I went there. And you can too at OCDFamilyPodcast.com.